now I'm going to talk about non-antibiotic topics in the ER. Again, ID is my specialty, but I've been working, I did my first year residency in the ER and have worked in the Borman ER for almost the last 3 years now. So that and ID are really things that I love, and especially the pharmacology behind a lot of it. Push-dose pressors. These are something that I'm going to talk about all these topics, but we're going to start off with the push-dose pressors. You might have heard of these. Anybody who's working in a very acute scenario could benefit from giving these small little doses of vasopressors like epinephrine and vasopressin to give a little boost to your patients. And where this is important, because blood pressure dropping to critical levels can lead to dysrhythmias and cardiac arrest. Usually a MAP of 45 is really that trigger zone. Also patients with trauma, anybody with head injury where you want to keep that blood flow to the brain, this can serve as your bridge, especially when you, even though most of the literature will tell you that pressors can initially be given through peripheral lines. Oftentimes, we wait for central lines to start infusing major doses of pressors. So your two big players here are phenylephrine, which is pure alpha effects, has no general effect on the heart, and it works super fast and lasts for about 20 minutes. And the same thing with epinephrine, except this does work on the heart. This has alpha and beta effects and makes it inotropic. Phenylephrine, the major time I use this, because a lot of the time we want that effect on the heart, so phenylephrine we don't use as much, but in patients with AFib RVR that have CHF, a lot of the time we're trying to bring down that heart rate, but we can't slam them full of fluids. So they have this labile blood pressure that hovers around a MAP of 60 to 70. Often when we're given the cardizem in those scenarios, I'm hanging out in the room with a little push dose pressor of phenylephrine. So if we drop them a little bit, we could bring up their blood pressure just until you get that heart rate down, which will then bring up the blood pressure based on the hemodynamics of the situation. This is generally very easy to make, and I always like to coach people on making these because nurses are going to feel uncomfortable. You could Google this. But really understanding that it's a vial of phenylephrine that is 10 milligrams per ml. So it's just a 1 ml vial. You take all the contents in that vial and you put it into a 100 ml bag of normal saline. That has now diluted it to an appropriate amount where you're going to have 1 microgram per ml in that sodium chloride bag. Always label it. You don't want somebody erroneously taking that. And then if you give 1 to 2 mLs, that's going to give just enough of that boost so that you're not going to bottom these patients out. When you're lowering their blood pressure in an attempt to lower their heart rate, you'll boost up the blood pressure, heart rate will come down, then you'll get the blood pressure that will respond to that lower heart rate because you now have better contractility. But the major one is epinephrine. We use this a lot in patients prior to intubation, patients in traumatic scenarios. It's been used by anesthesiology for years, so these are recognized as safe. The best way to do this is if any of you have seen the cardiac epinephrines, the boxes that come out, you're going to take the one vial and then you screw it in. Well, the vial is 10 mLs. You just take a syringe, take 1 ml out of that, you fill up the rest of that, so you have 1 ml in that, and you take normal saline, 9 mLs of that. So inside you now have a vial with 10 mLs of liquid, which has a concentration here of 10 micrograms per ml. And usually you give 1 to 2 mLs of that, and that's going to give you the blood pressure, the cardiac response that you need that will make intubation safer. I mean, intubation is often a very dangerous spot in very labile people where you do worry about them crashing on you at that point. I mean, in the last week, I've seen it happen twice in our ICUs. And I will tell you that I think a little push-dose pressor could have went a long way in those scenarios. And also, you don't want to give too much, because I've also seen dysrhythmias as a result of giving too much epinephrine in these very labile patients. So usually, again, 1 to 2 mLs, that's going to give you the boost you need for the Intubation often serves as a nice bridge until you could get central line in or peripheral pressors on board. Systemic lidocaine for pain. This has become a little more in vogue in the ED pharmacology as of late, especially for renal colic. There's some studies that have come out recently that shows that systemic lidocaine actually will reduce your opiate need. And in opiate crises that's occurring in society today, this is something that could perhaps lower the burden in some patients. It's used a lot actually in end-of-life scenarios. I know some pharmacologists that work with hospice, and they will use systemic lidocaine. And exactly how it works is unknown. It's thought that damaged neurons kind of are like the beacons for the systemic lidocaine, because you're given this systemically, you're asking yourself, well, why aren't my teeth numb? Why aren't my knees numb? Why is it going like a homing torpedo to the pain of my gallbladder? Well, one of the reasons is because actually you're dealing with nerve cells that are damaged, and that's the thought of where the systemic lidocaine is gravitating towards. Dosed at 1.5 milligram per kilogram, not really the best to give in people with a history of cardiac disease, because it is also, lidocaine is a 1A antiarrhythmic. So we worry about it a little bit in some of those patients, but it's generally safe. I would tell you in my experience, I've probably only done this. We have somebody in downtown Youngstown doing a study on this. I've probably done it in our Borman ER about 10 times, and I'd say it's been successful 6 or 7 out of 10 times. So it's an option. It's not going to work with everyone. Some people you're going to have to admit, some people you're going to have to give fentanyl to. But sometimes starting off with like a Toradol and then going with the systemic lidocaine, you could be doing them a favor of not giving them any opiates. Steroids in the ED. Yeah, this is a really busy slide here. I see steroids given so much. I could even say in the last 5 years, it's like everyone's getting a steroid for something. First off, ER, septic shock. A lot of people like to give steroids off the bat. There's not really great evidence that steroids provide any benefit in septic shock. The guidelines will tell you that after a person has had all their fluids and failed to gain resuscitation, appropriate fluid status, and hemodynamic stability, then it's reasonable to give some hydrocortisone when a patient's in septic shock. But again, this is something that's not necessarily a cure-all. Actually, because of some of the molecular advantages it has in some vitamin C protocols, it's given a lot more. I see it used a lot more now than it had been in the past, but the drug, again, the jury's out on how well it is, and a lot of the evidence doesn't suggest in septic shock that it's going to help you really regain that hemodynamic stability. Community-acquired pneumonia. If you're sending a patient home, there's no evidence that steroids do anything. Patients that are admitted, there is a little evidence, not great evidence, but a little evidence that might help with discharge rates and length of stay. But again, when we think of the function, what do steroids do? They actually can depress the immune system. We give doses of steroids in patients who need immunosuppression. So these drugs, yes, they have anti-inflammatory processes. They can make you feel better for short periods of time. And I would actually venture to guess for upper respiratory tract infections, patient satisfaction will be higher if you give a steroid. But fundamentally, the reason why they may not be better 3 weeks from now, even though some of the symptoms are better, but they're coughing, they're hacking, and they still don't feel better 3 weeks later, is because we are suppressing the immune system with these drugs. Sore throat, acute sinusitis, acute bronchitis, there's no evidence that steroids improve your outcomes. Again, they may improve some of the symptomatology, and I'm not going to deny that. But again, it's cost and benefit. Bacterial meningitis, it definitely does. That's one where you're going to want to give steroids before your first dose of antibiotics. Bell's palsy, a lot of people are talking, they wondered, well, should I give the antiviral, the steroid? Bell's palsy, the evidence for using antivirals only exists because there's not really evidence to show that it doesn't work either. The steroid with the antiviral, the steroid's the more important part. So if you're gonna send a patient home with that treatment for that, you usually give 60 milligrams for usually a week. Back pain, steroids aren't recommended. For the slew of headaches there, migraines, sometimes they could reduce recurrence. Cluster headaches, medication overuse headaches. Well, medication overuse, there's no real good evidence that it works. Headaches in pregnancy, it's a third-line option. Tension headaches, no recommendation. Sinus headaches, no reason to do that. Really, cluster headaches are the only source where it may provide some benefit. In migraines, it may prevent recurrence, but typically speaking, steroids are not going to resolve the symptoms of a headache. COPD exacerbation, definitely recommended here, usually for only 5 days. With this and asthma, understand that IV steroids are never better than PO steroids, but sometimes these patients cannot take PO steroids because of their symptomatology. So never, because of the volume of distribution of steroids, never will an IV option be better than a PO option, but IV options are often necessary when a patient cannot take PO. We give huge doses in MS exacerbations. Crohn's or colitis, let me touch back on the MS exacerbation. Usually it's a dose of 1,000 milligrams. And actually, a lot of the time we think we have to admit these patients, but sometimes they can be sent home on 500 milligrams of methylprednisolone for 5 days, which actually is a ton of pills, because I think the smallest dose is like 40, or the biggest pill is like 40 milligrams, so it's like 32 pills. But theoretically, they could be sent home if their symptoms aren't bad enough. And then Crohn's or colitis, prednisone, usually once in the ED, often they're going to be admitted when they have an exacerbation. If they're not, they're probably going to need a few more days, follow up with their GI doc. But yeah, steroids, I think I see them given a lot, and these are drugs that I so often see side effects with. People don't feel right. It affects their blood glucose. It makes them angry. I see these effects all the time on people with steroids. So yeah, short doses of steroids, not so much. The taper, anybody with steroids for less than 2 weeks. I would challenge anyone. I'm not going to go into a huge amount of detail of steroid HPA suppression and how the side effects develop and how adrenal suppression really develops and what you're trying to prevent. But there is no evidence whatsoever that patients on steroids for less than 2 weeks require a taper. None. It just mechanistically doesn't work like that. And I mean, this isn't anything new. I mean, this data has been around for 20 years. I learned it 15 years ago. And I still see it done all the time because, again, that's what was seen. We have guidelines that are 15 years old that hasn't been updated. So you don't need to taper steroids when you send somebody home with a short course of steroids. I'm going to touch on what Dr. Singh was talking about a little bit earlier, which is INRs on warfarin. Again, I work in an anticoag clinic, and in the ER you deal a lot with INRs that are wacky and you worry about it. But we also, in a day where I'm going to talk about the direct acting agents, worry about Eliquis and Xarelto. When a patient's not bleeding, I mean, I'll be in the clinic and I'll see people with INRs of 9, and you're like, oh, man, I hope they're not bleeding anywhere, and they tell you they're not bleeding, and you pucker up a little bit, and they have an INR of 9, and you send them home with 5 PO of vitamin K, and you have them follow up in 2 or 3 days. Most of the time, if a person is not bleeding, you don't need to do anything. You don't need to give them vitamin K, because then that's going to mess you up for the next week. You just need them to not get in a car accident, or not fall down the steps, or not pass out. But reality is, have them resume warfarin therapy when it's appropriate. So if a person has an INR of 4.5, you're going to send them home. Have them follow up with their PCP in the next week. If it's a little higher, say it's 8.2, tell them, hold warfarin. I tell them for the next 2 to 3 days, and I want them back in the clinic in 2 to 3 days. I would not advise them to restart warfarin until they talk to their primary care provider in those scenarios. If the INR is super high, give them the vitamin K and resume warfarin when it's appropriate. So again, give the vitamin K, have them follow up with their PCP 3 to 7 days to determine whether or not to restart the warfarin. When the patient is bleeding, this is one where if it's a minor bleed, I counsel patients, if they're bleeding when they're brushing their teeth, it's not a big deal. If they hit their elbow and they got a little bruise, it's not a big deal. If they're peeing blood, yeah, that's a big deal. If there's blood in their stool, that's a big deal. If it's minor, hold the warfarin, consider giving 2.5 to 5 milligrams of oral vitamin K, and again, follow up. The thing we really worry about is major life-threatening bleeds. And here is where, when I talk about the other agents too, where the dichotomy of major life-threatening bleed comes into play, and then the mortality as a result of reversing anticoagulation. So it's always, this is a very tenuous subject, and it's the one that I'm writing about this month to put on box, is exactly how do we handle this situation. Yes, if they have an intracerebral hemorrhage and it's expanding, it's not stable, they're younger, and they have an INR, it's elevated, you need to reverse it. And oftentimes we do this with 4-factor prothrombin complex. Kcentra is the brand name for that. Major bleeds are now defined, and they're all bleeds associated with hemodynamic compromise occurring in anatomically critical sites, usually intracranial, or associated with decreases in hemoglobin or requiring transfusion. What I tell all the docs in the ER, and my recommendation, even though I realize it's not my ass on the line, is when it's a GI bleed and they're stable, when it's another bleed and they're stable, I recommend giving fresh frozen plasma. All Kcentra is, all 4-factor PCC is fresh frozen plasma in a bottle. Usually they can benefit from the volume. Fresh frozen plasma, each unit's about 200 to 250 milliliters. And there's no difference in outcomes between giving fresh frozen plasma and Kcentra. You do want to reverse them early if that bleed is going to kill them. If they need a surgery in the next 30 minutes because they're going to die otherwise, yeah, you need to reverse them quickly. But if 5, 6 hours from now they're going to be sitting in the same spot, or they're going to be admitted and nothing acute is happening and their blood pressure is stable, fresh frozen plasma is just as good. And actually, it's pretty amazing when you look at the data for reversing head bleeds. I will tell you what got Kcentra its FDA approval is that it reverses INR within 30 minutes. And it has about a 72% hemodynamic reversal versus FFPs, which is about 60% when we're talking about what they call hemostatic efficacy, which is defined in a manner of ways depending on the actual location. With an intracranial hemorrhage, it's usually what's considered good or excellent hemostatic efficacy, which is less than 20% expansion of the hematoma. If you actually dig into the supplemental data that's hidden everywhere, FFP actually performed better than Kcentra in that study on reversing INR for intracerebral hemorrhage. A lot of different confounders with studies like this. It's a very tenuous state of actual understanding that most of these people, 50% of these people die within 3 months anyway. So it's very tough, but it's also important to understand that if you don't need to give Kcentra and they're stable, I tend not to recommend it because the flip side, these patients were reversed. They were on anticoagulation for a reason, and within 30 days, many will have thrombotic events. Why? Well, the reason why they were on that anticoagulant in the first place. And then with an intracerebral hemorrhage, for example, the guidelines recommend not restarting anticoagulation for another 4 weeks. So that tenuous time period of insult, reversal, no anticoagulation for 30 days are when you're having about 10 to 20% of people that are having thrombotic events. The direct-acting agents, the 2 big ones are rivaroxaban, which is Xarelto, and Eliquis, which is apixaban. I didn't know that Eliquis had anything to do with this event, but I will say that the recommendation I always make when we're sending people home on either Eliquis or Xarelto, from an ER standpoint, is I always say, I don't give a shit about 4 weeks from now. What I really care about is the next 3 weeks while the body's getting rid of that clot. Eliquis is twice a day during that time period. Xarelto is twice a day during that time period. Eliquis can be taken with or without food. Xarelto can be taken only with food because it needs that acid to help absorb the drug. I cannot tell you how difficult it is on the ground level for patients to eat every single meal, to always eat when they take a drug. If they miss a meal and they take that drug, the drug's not doing its side effect, its primary effect. So during that 3-week time period, the benefit of Xarelto is down the road. It's once a day after that 3-week time period. Eliquis is always twice a day. So there's a little more pill burden there. But for that first 3-week time period, if you're gonna send them home on one of these agents, I always say Eliquis because it's taken with or without food. So there's my plug for Eliquis. I don't work for Eliquis at all. I could care less about Eliquis, but if I had to put my mom on one of these drugs, I'm putting her on Eliquis. Reversing these, not the easiest thing in the world. The data for any of this is terrible. Indexa is the new drug. A trial was just published last month called Annexa 4, which showed that in intracerebral hemorrhages, this has 80% hemostatic efficacy, meaning that what they call good or excellent hemostatic efficacy, which in that trial, the study was not greater than 35% hematoma expansion within the first 12 hours. I actually think the biggest drawback of this drug is that it is super expensive. People will tell you, well, it's an initial bolus and then you get a 2-hour infusion. And what the study shows you is, yeah, we reduce factor Xa levels, but once the infusion stops, they go back up. Well, the hematoma expansion doesn't really go up during that 12-hour time period, so it's really not as bad as the naysayers will say. They'll say, oh, there's a ton of thrombotic events with this drug. 14% of people within the first 30 days died after they were given this drug. That's kind of scary. But most of them, everyone who died, was not restarted on anticoagulation. Again, these people were on anticoagulation for a reason. So the article, I think, was actually pretty poorly written. I don't think they highlighted their benefits as much. I think they focused on factor reversal. But at the end of the day, what's killing this drug is price. Most of these patients have poor outcomes any way you look at it, and your price is over $50,000 for most doses of this. It could be as low as it's usually either $28,000 if a person's on Eliquis and hasn't taken it within 7 hours, but if they're on Xarelto, have taken it within 7 hours, or on another drug, it's usually somewhere around $56,000 for one dose. So nobody wants to add to their budget. If they have 40 events a year, that's $2 million they're adding to their budget. For somebody whose outcome, there's no number needed to treat to calculate, but it's rarely the easiest outcome. So it's a cost benefit. Kcentra we use in these scenarios, no good data on that. FIBA, which is essentially Kcentra, but it has activated factor 7, no good data on that. Both of these drugs, they do show some reversal, trends of reversal, but they don't compare one versus the other. And they also don't compare one versus nothing. So these are trials of effect, but they're not trials of exclusion. But I do think that there is some good or better data with FIBA. This was a drug that people worry about because of higher thrombosis risk, theoretically, because of an activated factor 7, but there's no really good evidence of that. Real quick, opiate allergies. There's true allergies, pseudo-allergies, and adverse effects. Don't let the term pseudo-allergy scare you, or not scare you, because these can be very dangerous. These are often a major release of histamine that causes a release of mast cells and eosinophils and can cause people to have some significant side effects. True allergies just mean that it's antibody mediated. This is what we call anaphylaxis versus this is what we call anaphylactoid. Typically, when a person has a true allergy, you want to avoid, or even a pseudo-allergy, you want to avoid drugs of similar classes. So if you have a person who is allergic to Demerol, which is meperidine, it's not the best choice to give them fentanyl. They're allergic to like morphine or codeine, for example, well, maybe fentanyl is a decent choice. If they did have anaphylaxis to an opiate, I would try to stay away from it. But when they have a pseudo-allergic reaction, happen the first time you gave it to them. You know, everyone who's on Dilaudid who wants Benadryl first, it's because they're having a histamine release when they get that Dilaudid. Give them something else. You know, they don't need the Dilaudid, give them fentanyl. That's probably not the best answer in the opiate crisis, but you know, give them morphine, give them something else. Because if they handle Dilaudid with the Benadryl first, they're gonna handle morphine with the Benadryl first too. A lot of people will, before people give opiates, they'll give Zofran first. There's no evidence that this has any benefit. Actually, the one study that's from 2017 that looked at it actually found, interestingly, that 30 minutes after the opiate was given, there was a statistically significant more patients in the opiate plus Zofran group versus opioid monotherapy group that had nausea. It doesn't really work. People think it works. It really, I mean, there's no evidence that it does. And even though we worry a ton about Zofran, people ask me about Zofran and QT prolongation and pregnancy all the time. What I would tell you is there's only 12 reported cases of arrhythmias with Zofran in over 1,100 citations. So I'm not here to poo-poo Zofran and QT prolongation, but typically it's not something you really have to worry about. AFib RVR, this is the last thing I talk about because I get asked about it all the time. What's the best drugs to use? I think Cardizem, without a doubt. There are very few studies that compare Cardizem versus metoprolol. I know some cardiac guys that like to give metoprolol first, but the data will show that this is, I don't know if I have it on here, yeah. Cardizem's about 96% effective within getting a heart rate under 100 in 30 minutes, which I think that's a little elevated in my experience. Metoprolol is only about 50% effective here. So I always say Cardizem, give as the package insert says if a person has very good blood pressure. That's 20.25 milligrams per kilogram. And if that doesn't work, 0.35 milligrams per kilogram. I always see 10 milligrams of Cardizem used. Cardiologists will tell me, boy, I love when people do it the old way, which is just the normal way of giving an appropriate weight-based dose. That's how you affect the AV node the way that you want to affect it, which is where the drug works. If the blood pressure is not good, we'll actually put it in a bag and infuse it over 10 minutes. That way, if you're dropping the blood pressure too much, you could shut off the infusion. And if it doesn't work over that time period, you give another 25 milligrams. So usually it's 25 milligrams over 10 minutes. If it hasn't worked, we repeat the dose. But if their blood pressure, we do Q3-minute blood pressures, and if the blood pressure drops too much, we shut the infusion off. If the blood pressure is really not good, meaning that you're kind of worried you're going to bottom them out, that's when I use the push dose presser like I was talking about earlier, which is basically to use this version here, infuse it over 10 minutes, but also give a push dose presser when that heart rate, or when that blood pressure, really for me, when the MAP is anywhere under 65, we give a little push dose presser. Metoprolol, I think a lot of the failure is because it's also misused for AFib RVR. It should be 5 milligrams. In 5 minutes, if it hasn't lowered your heart rate, you give another 5 milligrams. And in 5 minutes after that, if it hasn't been lowered, you give another 5 milligrams. So over a 10-minute time period, from 0 to 10 minutes, 3 doses of metoprolol 5 milligrams should have been given if you're dosing it appropriately for AFib. Often that's not done. I see 5 milligrams given, oh, heart rate's still high. 50 minutes later, give another 5 milligrams. Well, you've missed the boat. You're not going to affect the heart the way you want to. Digoxin's one of my favorite is because, well, blood pressure's low, heart rate's low. Let's give them Dig. I mean, Dig isn't a bad choice here, but from an ER standpoint, especially when you want to get them out of there in the next 2 hours, Dig takes 1 to 4 hours to work. And it's usually on the longer end of that. And the full dose requires 24 hours to really digitalize them. So I usually think it's one that looks good on paper, but doesn't really have a lot of legs to it. Amiodarone, I don't like to use it in the ER. A lot of drug adverse side effects. This is one I see a lot of hypotension with. And yeah, like I said, a lot of side effects. Drug-related side effects, as well as drug-drug interactions. And that's pretty much it for all of that.